Good morning and good afternoon from wherever you are connecting today. My name is Camille Collins-Lovell, and I'm very excited to welcome you to this webinar about community health workers, high impact practices, challenges, and opportunities. This is offered to you today by the IBP initiative and by Family Planning 2020. We are happy to involve Pathfinder International as well as the Frontline Health Workers Coalition and IntraHealth to bring you several presentations about the challenges in applying the high impact practice of community health worker involvement in family planning at community level. So we're going to begin today by presenting the high impact practice brief, which is available to you in the chat box is the link, so you can have a look at that. And we'd also like to draw your attention to an opportunity for you to share more information about projects you may be working on. So there's also a link to a form where you can add your community health worker project to the HIP map. And that is in the chat box again, the link, right? So you'll be able to describe your program and different aspects of the high impact practice that you may be using to share your experiences and learning with other people. So we invite you to take the time to look at that, look at the map and also to add your own project. I think that many of you who are joining today are already familiar with this HIP brief and the practices described there. If you're not, we invite you to look at it. And today, much of what we're going to talk about is related to the practices described there. Now this morning, I'd like to introduce myself very briefly, so that's our next slide. We went through that one. This is me, I'm Camille Collins-Lovell, and I'm happy to describe a little bit of our work at Pathfinder, but mostly today we're going to be talking in broad strokes about how this HIP is applied in our work. So the next slide shows you some of the other high impact practice briefs which are available. And again, to the one we're going to talk about today, the high impact practice is to train, equip, and support community health workers to provide a wide range of contraceptive methods. And there are other supporting activities around provision of contraceptive methods that we'll also be talking about. Next slide. Some of the challenges, and our first presenter, Laura Hurley, who I will introduce in more detail in just a moment, is going to be talking in more detail about both the high impact practices themselves and the challenges we face generally when we do this work. I'd like to just mention a few of them, which will be familiar to those of you who are doing this kind of work. Ensuring commodity availability so that our community health workers have the materials that they need in order to do community-based distribution, and also I would say to do the appropriate counseling education. There are also other materials that they need and do not always have access to. Remuneration and incentives are something we think about a lot because community health worker motivation is something that must always be on our radar as far as how to keep these projects working well. Relationships with clinical service providers. So when we talk about task shifting and task sharing, this involves relationships with service providers at clinical level, and those relationships, the nature of those relationships change. That's another area we'll be talking a little bit about. Counseling skills, including how to address social norms around family planning. Many times our community health workers are trained to provide information and education, but actually addressing some of the complex social norms, especially around sexuality and reproduction, can be a real challenge for our community health workers. And finally, community health worker reporting and monitoring is a major challenge because we often don't get information back about the work that they are doing, or the information we get back is limited in some way, which hampers our ability to make decisions and to improve our support. Next slide, please. Now, something that our other speaker, Mahesh Srinivas, who I will introduce in more detail in a moment, will be talking about, is how we apply the HIP in countries where policy also limits the kind of work that community health workers can do. Sometimes in countries with the most need of community-based provision of family planning, community health workers are allowed to distribute a more limited range of short-acting methods or perhaps no methods at all. So in those cases and contexts, advocacy is an important part of work that can be done to increase access at community level to a wider variety of methods. But even in these kinds of contexts where policy limits what community health workers can do, community-based counseling with good referral and follow-up systems can be effective at increasing access. So when Mahesh discusses his work in India, we'll hear a bit more about the role of quality counseling at critical moments is very important, especially for postpartum family planning in context with limited community-based distribution. Next slide, please. Before I introduce Laura, I would just like to say a word about logistics and questions. We'd be very happy to take your questions, and we'd encourage you to type them in the box on the menu that says questions. And we will be tracking your questions, and at the end, after all the presentations, then we will select some of the questions for our various presenters. If you'd like to direct your question to a specific person, to Laura or to Mahesh or to Vince, please feel free to direct the question to someone specific or just leave it open if it's for everybody. So that's where your questions can go in the question box. And also if I believe that we also can mute, I think all the audience is already muted, but you may want to mute yourself, or if you are accidentally muted, you may need to, for our presenters, make sure that you are unmuted when it's your turn to present. So we're going to begin with Laura Hurley, who joins us today from IntraHealth. She is a program manager and has experience in many countries. You can read her profile here. She's been supporting projects in West Africa and Madagascar, and her international expertise is in reproductive health, maternal health, family planning, community health, and community participation. We're very glad to have Laura here today. Take it away, Laura.
Great. Thank you for the introduction. So as Camille said, I'm going to talk today about strategies to implement high-impact practices for effective CHW programs. The examples I'm going to provide are from sub-Saharan Africa. My personal experience working with CHW programs is in Rwanda and in Madagascar. Next slide. So I've organized my talk this morning to present some of the barriers to implementing the CHW high-impact practices, or HIPs, and then provide some strategies to address them. I will present the barriers and strategies around the 4 key implementation components outlined in the CHW HIP brief, which you have in your panel to the right. These 4 essential components to ensuring CHWs can provide quality care are integrating CHWs into the health system, training CHWs, equipping CHWs, and supporting CHWs. Next. Some of the key barriers to integrating CHWs into the formal health sector that I have encountered include resistance from health center staff, weak referral systems, and HMIS systems being slow to integrate new indicators. In Madagascar, there are various reasons for resistance from health center staff. Supervising CHW staff can add to their already heavy workload. CHWs may decrease their payment for services or affect performance-based financing incentives or health center financial management. In addition, health center staff in Madagascar also complain that CHWs also surpass their role and provide services outside of their scope and outside of their training or expertise. And we all know weak referral systems are a problem everywhere in Africa. Transportation, long distances, and communication for referral and counter-referral are all challenges. Finally, HMIS and LMIS, Logistic Management Information Systems, are very slow to change. CHW programs are hard to monitor or support because information about the programs are not available beyond the health center that the CHW reports directly to. Next slide. To ensure integration into the health system, health center staff have to be shown that CHW system can lighten their workload and help them prioritize their work. An important benefit of CHWs is that their link to formal systems can lead to earlier referral, and early treatment leads to improved health outcomes. When doctors start receiving less patients who waited too long to come to the health facility, they will recognize this value that CHWs can bring. So advocacy is important, and it can be helpful to use champion health workers who've already learned these benefits to convince their peers of the benefits of CHWs. Another important strategy for effective integration is to ensure CHWs understand their limitations. They need to know danger signs, they need to refer for long-acting methods of family planning, etc. As I mentioned, one quality issue in Madagascar is that CHWs perform tasks outside their training, such as treating older children for childhood illnesses or supporting labor and delivery. They should refer, but for them to do that, there has to be a functioning referral system in place so that they can refer. And finally, whether it's for referral, counter-referral, supervision, or support when they have questions, CHWs need to be able to have regular communication with health facility staff. Programs should consider mobile technologies, transport costs, and/or bicycles to facilitate interactions between CHWs and health facility staff. Next. As stated, CHWs need to recognize their limitations. They need to know when to refer and how to refer, and they need feedback on their referrals through counter-referrals so that they continue to refer and understand if they're referring appropriately or not. They also need to offer their clients suggestions for transportation and funding for services as needed. In Madagascar, we worked with commune-level social development committees to support health in their communes. They were led by the mayor or assistant mayor, but included a large group of community stakeholders, including village leaders. Their work included helping communities develop transportation solutions for referral from villages to the health center, especially in emergency situations. Solutions developed by individual communities differed from community to community, and the status of the village during rainy season, but included things like stretchers and bicycle ambulances and canoes. We also coordinated with village savings groups to help communities overcome the financial barriers to access to care. Next slide. As most of us know, M&E is often an afterthought, and as mentioned, CHW programs need to be monitored. There has to be a plan to integrate community-level data into the formal HMIS and LMIS before a national program begins. Likewise, data management needs to be integrated into the initial CHW training as well as refresher trainings. Data collection and management should be as simple as possible while still fulfilling monitoring needs. This is often a difficult balance. Due to challenges with travel, consider integrating mobile data collection for both health services and logistics if feasible. Next. The second key component to CHW programs in the HIP brief is CHW training. While it seems straightforward, there are various challenges. We know that regular refresher training improves performance, but training is expensive. In most countries, the CHWs provide integrated services, including child health, maternal health, and family planning. This is generally the most efficient for service provision, but it also means that trainings can be long and there's a higher need for more regular refresher trainings. Also, when CHW retention is low, high turnover requires additional training for replacement CHWs. Next. To overcome the barriers to capacity building, Facility-based supervisors need to be engaged in providing regular refresher training. In Rwanda, CHWs come into the health facility on a monthly basis to bring reports and gather together for technical updates or a refresher training presentation. Financial strategies have to be put in place to ensure this sort of continued training of current CHWs continues. And also, you need financial preparation for full training for newly recruited CHWs to replace, natural attrition. Updates can also be provided via mHealth strategies, but this requires both literacy and access to a mobile phone, as well as a mobile phone network. CHWs need to be trained in behavior change communications, both to care-seeking behavior and for addressing social norms for family planning acceptance, as Camille mentioned earlier. Low literacy job aids are essential, both for the CHWs and for education and counseling materials they will use in their communities. Next slide. Services offered need to reflect the needs of the community and should be comprehensive without overloading the CHW. Appropriate workload really depends on a number of different factors, including the number of households the CHW supports, distances the CHW must travel, and whether or not the CHW is being compensated or is a volunteer. Volunteers have to have time for additional activities to make a living. Another aspect to ensuring a full range of services is to ensure family planning counseling includes the full method mix. Injectable methods should be offered at the community level. Many pilots have been completed, and there's always been success. So my personal opinion is it's time to move on and accept that CHWs can offer injectable methods of contraceptives safely and effectively. Referrals should be given for LARCs and permanent methods. Training of CHWs should emphasize the importance of choice during counseling, and care should be taken to not overly focus on or recommend any specific methods. Next slide. The third key component to CHW's programs is equipping and supplying CHWs. Barriers include the cost of equipment and supplies. Stockouts are common, and there's often a lack of attention to the supply chain down to the community level. In Madagascar, stockouts are extremely common during the rainy season because the supply chain breaks down as roads flood. Next slide. To overcome barriers, projects need to budget appropriately for startup supplies and equipment. Depending on the context, that may include uniforms, boots, umbrellas, bags, job aids, commodities, bicycles, mobile phones, and data collection tools. The importance of equipment as a motivator should not be discounted. CHWs in Madagascar, who are primarily volunteers, are very motivated by equipment and supplies. They say that the smock they receive increases the respect that they receive from their community, and obviously items like cell phones and bicycles are significant commodities in rural communities, and they're often a source of pride. In assuring resupply of stocks, job aids and tools for tracking clients or for data collection are often overlooked but need to be prioritized as they're essential to the CHW. Projects as well as governments need to invest in the supply chain. One strategy is to use mobile technologies for community logistics to better monitor CHW needs, if that's feasible. Another strategy is to engage the community in supporting the supply chain. In Rwanda, the health center quality improvement teams work to prevent stockouts at both the health center and for the CHWs in the health center catchment area. In Madagascar, the commune-level social development committees appoint a supply point manager to manage the social marketing supply chain, which is supported by PSI, where CHWs can resupply their stocks. Next slide. The final essential component to CHW programs is supporting CHWs. This includes supervision and general motivation. There are various challenges to supporting CHWs, including supervisor workload, geographic distance, and transportation issues that create obstacles to providing supervision. Likewise, there are various factors that contribute to low motivation and retention that should be prevented or addressed to develop a successful CHW program. Next. To overcome barriers to supervision of CHWs, excuse me, consider introducing more regular supervision by phone or SMS. In Madagascar, interactions are supposed to happen monthly when CHWs come to the health facility. However, this is often impossible during the rainy season. So phone or SMS supervision could ensure increased communication during these periods. Another strategy is to take high-functioning or champion CHWs and promote them so they become supervisors of newer or lower-functioning CHWs within a reasonable distance to them. Finally, a strategy we have used in both Madagascar and Rwanda is community engagement approaches to engage the communities that CHWs support, to support them in return and be held accountable for CHWs receiving the support they need, including necessary supplies and equipment for transportation. One example of this is that in Madagascar, communities often build health huts for the CHWs so they have a place to work and have confidential interactions with their clients. Next. Sorry, I needed a pause for my throat. Overcoming barriers to motivation and retention can be accomplished in different ways. Careful selection and recruitment of CHWs from their own communities is one strategy that helps ensure retention. CHWs that are not interested in their position or not qualified usually do not last long. There are often challenges with CHWs that are not literate. Likewise, retention is very low when CHWs are sent to rural, hard-to-reach areas where they are not from or have no family to connect them. Another key retention strategy is ensuring both financial and non-financial incentives. I've discussed several non-financial strategies already, including equipment and supplies, the building of health huts, and the respect they receive from their communities. But financial incentives are important too, especially if the workload becomes heavy and they don't have the sufficient time for activities that generate income or food for their families. In Madagascar, CHWs are volunteers, but they do receive a small dividend from the sale of social marketing products. Finally, gender dynamics can play a role in motivation and retention. In countries where CHWs are not chosen from their community, retention is much lower for women who have been sent to remote areas. Likewise, in some places, it's not appropriate for a woman to discuss condom use with a man or for a man to discuss birth planning with a woman. In Rwanda, the government recruits CHWs who they call binôme, meaning each village more than 5 kilometers from a health center has one male CHW and one female CHW to overcome these gender issues that can affect a CHW's performance. Next. So I've covered all my main points, but I just wanted to quickly recap some of the key recommendations I've covered here. Integrating CHWs into the health system can be achieved through advocacy and clearly defined roles and responsibilities, as well as strengthening the referral system, which can be achieved through training and community engagement. Monitoring of the CHW program can be achieved by integrating the system into the national HMIS and LMIS. And to ensure quality of care, regular refresher training and useful job aids must be provided, and family planning needs to cover the full method mix. CHWs need equipment and supplies to do their job well, and the investment should not be overlooked when planning a program. Finally, CHWs can best be supported through regular supervision, community engagement, incentives, and taking gender considerations into account. Next. Thank you very much for your attention. I look forward to discussing further. Thank you.
Thanks so much, Laura. This was a really excellent overview of many of the challenges and solutions, or at least ways of responding to these challenges when we work with CHWs for family planning at community level. I'd just like to mention again something that you brought up, Laura, and is very important, I think, for our audience to know, is that there's lots of good evidence about the safety of longer-acting methods, especially injectables, provided by community health workers at the community level. And there is also now some evidence of the safety of involving community health workers in providing even implants coming from Ethiopia, where health extension workers are involved in supporting community-based distribution. So I think we know that there is this body of evidence, growing body of evidence of the safety of provision of methods at community level. And I know also it's important to mention some new technologies like the Sayana press, which is increasing ease and safety of delivery of injectables at community level. But we also need to think about contexts where those methods are not yet available, or a more limited range of methods is available. So we are going to listen now to Mahesh Srinivas, who is going to talk to us about how community health workers in India are involved in providing counseling, referrals, and some methods at community level, and also how many of the challenges that you've just mentioned, Laura, how their project in India is responding to those same challenges. So without much ado, here is Mahesh to tell us about increasing access to postpartum family planning, specifically through community health workers in India.
Thanks, Camille, and hello and good morning, good afternoon to everyone. Today I would like to share our experience from India on increasing access to postpartum family planning through community health workers. And I think Camille has already given a good outline, so I would dive straight into the presentation. Next slide, please. India refers to its community health worker cadre as ASHAs, which stands for Accredited Social Health Activists. They are women from the community who work for the public sector, and on an average, an ASHA has attained secondary education. They are volunteers, but of course with performance-based incentives. They have a broad health mandate, including family planning, and they are supervised by the auxiliary nurse midwives. Next slide, please. So in terms of the roles that ASHAs play, as I said, they have varied roles. With respect to family planning, they undertake awareness, community-based distribution, referral, and follow-up. The awareness, or the IPC, interpersonal communication, is undertaken at the household level by referring to the list of eligible couples that they have with them. In terms of distribution, the most commonly distributed family planning products are oral contraceptive pills and condoms. In addition, they do educate about LAM. Next slide, please. The ASHAs are in many ways a cadre that takes into account many of the HIP recommendations, like they come from the community and are paid for performance. But however, they do face some limitations. Firstly, the range of products currently that they provide is limited because of the government's policy on injectables, IUDs, and implants, especially at the community health worker level. Secondly, the ASHAs provide limited counseling due to both limited skills as well as due to an expanding workload. Thirdly, since ASHAs are mainly community-based workers, they do not have strong links to service providers based at public institutions. So we have a situation where the providers are not aware to what extent the clients are counseled when they come in. And on the other hand, we also have a situation where the ASHAs have trouble with following up clients who adopt a family planning method. Next slide, please. Yeah. Coming to the postpartum family planning per se. Now, this is a critical period for spacing, and it's estimated that the unmet need for family planning during this period, during the extended postpartum period of 1 year, is around 60%. In the recent years, the institutional delivery has been increasing in India. So while this provides an opportunity for postpartum family planning service provision, too often we see that the counseling does not happen at the right time. So such as the during labor or immediately postpartum. And also it's noticed that key decision-making family members such as the mother-in-law and the husband may not be around when the woman delivers. And therefore the woman does not want to make a decision on the PPFP method while still at the facility. So it's very important, or I would say imperative, that the woman and family members are counseled during the antenatal or the pregnancy period, and a decision made on appropriate postpartum family planning method. Next slide, please. Pathfinder initiated a project called MATRIKA. We are in the 3rd year of the project now. This program is supported by funding from MST through MST for Mothers, the company's 10-year, $500 million initiative to help create a world where no woman dies giving life. The project has a continuum of care approach towards reducing maternal mortality. Today I would just be focusing on the approaches towards postpartum family planning, wherein we are focusing on strengthening community and institution components of PPFP. Next slide, please. The project covers a population of around 8 million spread across 3 districts in the state of Uttar Pradesh. What India is to the world, the state of Uttar Pradesh is to India. With a population of more than 200 million and an estimated 15,000 maternal deaths annually, there's an urgent need to ramp up PPFP services in the state. Next slide, please. Like as noted previously, the awareness of community-based awareness as well as community-based distribution undertaken by the ASHAs were limited in a variety of ways. The project has focused on improving this by firstly, like I would say, IPC and counseling techniques during the antenatal period. We have trained around 2,000 ASHAs so far on this. We've also been focusing on the referral and follow-up mechanisms which have been streamlined to bridge the communication gap between the ASHAs and the institutional service providers. Simultaneously, we have also improved the communication tools being provided or being made available to the ASHAs for use in the community. And of course, while doing this, we have also undertaken trainings of service providers on clinical skills such as IUD and PPIUD. Next slide, please. In addition to supporting ASHAs directly, we have introduced a new cadre called the Family Welfare Counselor. They are full-time professional counselors who are based in public health facilities with high load of institutional deliveries. We have selected facilities where 100 or more deliveries happen in a month. The FWCs are able to provide higher quality counseling to women and couples, and we currently have 15 such counselors under the project and are functional for the past 1 year. Next slide, please. So what does the counselor exactly do? Apart from the one-on-one counseling at facilities, the counselor also travels to the field on 2 days in a week, every week, to counsel women at immunization sessions and at homes. So that way, they're able to reach women who deliver at homes. In the state where we are working, the home delivery is as high as about 40%. More importantly, the field visits by the counselor also provide on-site supportive supervision to the ASHAs on counseling and follow-up. In essence, therefore, the family welfare counselors act as the link between the ASHAs and the facility-based service providers. This did not exist previously. In terms of distribution of contraceptives, the counselors are similar to the ASHAs and distribute OCPs and condoms. Next slide, please. This graph, this slide indicates some of the results, the impact so far. The graph compares data of family planning clients or adopters in the 15 facilities before and after introduction of counselors. So the blue bar there is before introduction of counselors, and the green bar there is after introduction of counselors. The data includes all available family planning methods except condom users. So when we look at this, we see a substantial increase in family planning adopters after introduction of counselors. In addition to the data, we are also seeing partners and husbands more involved in accompanying their wives to the facilities when they have interacted either with the ASHAs and FWCs during the antenatal period. Next slide, please. The improvement in family planning adopters, like we saw in the previous slide, which is about 95%, is attributed to improved capacities of ASHAs to counsel, provide, and refer clients. The improved communication tools that ASHAs now have that help clients make informed choices. And of course, the link in the form of the counselor. In particular, we have noticed that the PP-IUD acceptance has increased significantly. Next slide, please. Thus, in order for this HIP to work, we feel that ASHAs should focus on critical periods of counseling, primarily the antenatal or the prenatal period and immediate postpartum counseling. There is potential, we feel, for introduction and use of mobile phone-based applications by ASHAs for awareness, for follow-up and reminders to clients. As a way forward, we would be looking at transitioning the family welfare counselors to the public health system in the closest possible way to the existing model. And of course, lastly, I would say ensure and assure. So ensure that ASHAs are connected to public health facilities and assure quality services, which is where we counselors play an important role. Next slide, please. Thank you. Thank you very much.
Thank you, Mahesh. So now we've had an opportunity to look at some of the broad challenges that we know are experienced in many projects. And then we've had a chance to look at a specific case in India. And now we're going to invite Vince Blazer from Frontline Health Workers Coalition, who's been listening attentively and has, we're sure, lots of responses and comments on what we've been hearing about so far this morning. We're also very pleased to have Vince because we know he has a perspective on some of the policy issues that sometimes as implementers we can get lost in the forest of our projects, and it's also very important to have a broader view of policy. So welcome, Vince Blazer.
Thanks, Camille, and thanks, Laura and Mahesh, for some really great presentations, and for the IBP initiative for organizing this today. It's really very interesting for me to hear about. First of all, just to give a bit of background for those of you who don't know about the Frontline Health Workers Coalition. We're an alliance that just started in 2012 of U.S.-based organizations together advocating mainly to the U.S. government, but also on the global stage to increase attention and focus on the needs and investment in frontline health workers in developing countries. And so our members include both Pathfinder and InterHealth International, where the Frontline Health Workers Coalition is based. And the slide that we have up here is the timing of this webinar came really great because for the past 4 years, we, along with WHO and Global Health Workforce Alliance and others, have been celebrating something around World Health Day, which World Health Day is today, called World Health Worker Week, which is really just a week-long celebration to honor and support the contributions of and impact of that health workers make in our communities around the world. And we mainly do that through social media and other media pieces, which we're engaged in this week. So, join us online with the hashtag is WHWWeek. And there's many different ways you can get involved through our portal online, and so would really like many of you to get engaged this week and really get the message out there about all the great things that frontline health workers are doing, and what we just heard about community health workers doing in the area of expanding access to family planning services. So in reaction to the presentations today, a bit of a broader scope that we've certainly seen in the past 5 years, especially, but 5 to 10 years, a really increased interest and commitment to the utility of community health workers in expanding access to services. So in the same conversation that we're having here today about family planning, there's similar conversations that are having across the full spectrum of health services, whether it be maternal child health, HIV/AIDS, malaria, etc. So there's really a lot of discussion going on in many countries about about what can community health work, what is the potential for community health workers in expanding access to services, and what are the barriers to doing that. And so in the area of family planning, so one, I think it's good to keep that in mind as we're discussing we're discussing access to family planning in general, is that this same conversation is happening in other areas of global health. And so in thinking about how the full range of services fit together and what community health workers might be doing. Now that being said, we in the area of family planning, we are often telling lawmakers that the areas where there is the least access to health workers, there's the biggest gap in health workforce, also very much match the areas where there's the largest unmet need for family planning. We took a look at the USAID focus countries for family planning, and 23 out of those 24 countries are designated health workforce crisis countries by the WHO. So really, there's an there's a pretty exact match of where there's the least access to trained and qualified health workers, there's the greatest unmet need for family planning. So certainly the promise of community health workers, it provides a lot of, there's a lot of potential there for community health workers to expand access to family planning. And I think what was borne out in both of those, Laura and Mahesh's presentations there is that one of the greatest strengths of community health workers is really knowing their communities. That of course we all know that there's significant, often cultural, social, and economic barriers for people to access family planning, and nobody really knows that better than those barriers better than people in their own community, and they definitely differ depending on which community you're in. So I think that that really holds the most promise. That holds a lot of promise. In terms of the barriers, it was really interesting to hear a little bit about both from Laura in the different contexts she's worked in West Africa and elsewhere, and then from Mahesh in India, where there are barriers in terms of competencies and follow-ups for health workers, some of the tensions between cadres, which we've seen in a lot of areas of health workforce, and so those are definitely barriers that governments need to address as they look at ensuring that or expanding community health workers, expanding what community health workers can do in the family planning area. I think that one challenge that, as we kind of think about this globally going forward, is that with community health workers, especially in comparison to other cadres, there's a wide variety of definition and of what a community health worker is, and a wide variety of who they are depending on the country and sometimes within the country. The Frontline Health Workers Coalition in September of 2004 published a policy paper called Better Data for Decision Making for Community Health Workers. They called for the global community to come around a standard definition for community health workers. We recommended the ILO definition just as a starting point. It certainly doesn't have to be the definition, but that lack of definition and of the competencies needed for community health workers make it difficult, I think, in countries especially that are just rolling out their CHW programs to really have an understanding, especially among other cadres, of what community health workers are providing, and certainly the challenges of remuneration and all of that are major challenges in different contexts. So it was also really interesting for me to hear from Mahesh's about the family welfare counselors. Just keeping in mind, I think when we think of community health workers, we're often thinking of, getting out to the most remote areas, which is certainly needed and certainly hold promise. But especially in the area of family planning, a lot of the unmet need is at those high volume facilities. I was in Senegal last year looking at IntraHealth is helping to roll out Ciana Press, which, as Camille mentioned, holds great promise, and there's great demand for it in a lot of the clinics that I visited in Senegal, and so having those family welfare counselors available for at those high volume facilities and doing the follow-ups in communities, I think really holds some great promise. So some good promise, but some definite questions. I think one thing that I think will be great to keep in mind is a lot of the information that's in the brief and is from countries that have a little more established CHW cadres. So Ethiopia, India's ASHA cadre is also very well established and known. That's not the case in a lot of other countries. So both in terms of keeping that in mind in terms of harnessing the best practices that they've seen in more established cadres, but also realizing that community health workers may not be able to do the same in a country where it's just being rolled out that they are able to do in Ethiopia. I also thought that it was interesting in what Laura mentioned, or maybe it's Camille, about pairing the male and female community health workers to go out to rural areas with the safety issue, and that's an interesting concept to me that that came out of the presentation. So those are just a few of my observations, and I think I'll turn it back over to you, Camille, to open it up for questions. I had a couple of questions myself, if it's okay for me to lead off the questioning.
Yeah, Vince, I think that would be great if you wanted to lead with a couple questions, and then we'll take questions.
Great. So, Laura mentioned in her slides one of the barriers is resistance from other cadres of health workers, and I'm curious if Mahesh has seen much of that from a longer established cadre with the ASHAs in India, and what both Laura and Mahesh's experiences have been in helping to alleviate the tensions between other cadres of health workers and the community health workers. So maybe Mahesh first.
Yeah, thank you. I think one of the key developments in the recent months has been the introduction of another new cadre as far as the ASHAs are concerned. Now, before that, we all know that it's been about a decade now, close to a decade since ASHAs have been there. And overall, I think everybody undoubtedly recognizes the value addition of this cadre. So in that sense, their immediate supervisors until recently, who were the ANMs, the auxiliary nurse midwives, or the female health workers, they really felt supported. In terms of managing the ASHA cadre again, the ANMs were finding it hard to provide supportive supervision. So many of the governments have now introduced another cadre called the ASHA facilitator. An ASHA facilitator is herself an ASHA, but probably one of the smarter or better performing ASHAs, and each ASHA facilitator is assigned a group of 20 ASHAs to mentor and support. And again, beyond the ASHA facilitators, you have supervisors at various levels to support them. So what we have seen is the development of an entirely new cadre which acts as support system for the ASHAs.
Thanks. And has there been any tension among the ASHAs with that new cadre?
Not really, because as I said, I think the ASHA facilitators and the others are recognized inherently by the ASHAs as more qualified, or one who perform better, or better communicators. So they definitely recognize a better skill in their supervisors.
Great. Okay. Laura, you have any thoughts on this question?
Yeah, I think that it is a relevant point that the ASHAs are longer standing. So I think it's likely a tension that exists at the beginning of an introduction. And, I didn't talk much about Mali. I talked more about Rwanda and Madagascar, but Mali has been introducing a new cadre, and they're, in that process of experiencing growing pains and figuring out the best strategies to introduce this cadre of CHWs that are providing services. So they're a little behind in the global world, but they've traditionally had Relay, who do more of the community sensitization and behavior change communication. But I think in countries where I've worked more directly, I mentioned advocacy about the benefits of CHWs to the facility-based health providers as a key strategy. I do think these things take time. Like, I think in India, we're sort of beyond that. the ASHAs have been proven to be successful, and so it's less of an issue. So, time to see the benefits that CHW can bring. And, as I mentioned, one of the big ones is early referral, or earlier care seeking, not necessarily early, but earlier care seeking. And then, but I do think some other countries have used incentives to supervise for the health providers, because they are taking on additional tasks. So, some, I don't know full details, but I think there are some incentives through performance-based financing or other mechanisms for the task of supervising and managing all the data that comes in from CHWs.
That's great. That's really interesting. I just had one more quick question for both of you. As as I've mentioned about the trend in a lot of task shifting to CHWs across the service spectrum, and I'm curious, the challenges beyond ensuring that CHWs have the right skill set. Have either of you seen community health workers being overwhelmed with the tasks that they're given, and in any of the ways certain localities or countries have helped introduce new family planning services and other services in ways that were manageable for the community health workers? Either one, if you guys.
I guess I can start. I think that I mentioned it a little bit in my presentation, that I have seen CHWs in Madagascar sort of struggling with the balance of doing the voluntary community health work and doing income-generating activities, or in most cases farming, so they have food for their families. And because we worked with these community engagement groups, I can't give you statistics on this, so this is more anecdotal, but through an evaluation of our community engagement approach, one of the things that came out is that communities sometimes pitched together during heavy harvesting farm times and would farm the CHW's land, so they had time to stay at the health hut and provide services.
That's really interesting. Mahesh, you have any thoughts on this question? Sure.
Yeah, sure. Definitely, I think when ASHA started out, they had limited responsibilities, and even today they are there for a population of 1,000. But I think what we have seen is that over the past years, they started out with services related to mother and child, but I think this has slowly expanded to family planning. and more recently or in the past few years to even immunization, tuberculosis, malaria, and so many other things. One of the things that probably no one expected in the initial phases was the additional workload that ASHA undergoes when she accompanies clients to services. So invariably, for many services, right from institution delivery to sometimes family planning and other services, the ASHA accompanies the client or the woman. So this actually has added a lot of workload. And there are also recently, ASHAs are being more involved in trainings or review meetings, reporting. ASHAs were earlier not reporting at all, but more recently a systematic way of reporting has been introduced. So definitely workload has increased, and the way I think family planning still becomes a priority is because it's a priority for most state governments. So whatever is the priority by the state, I think that the ASHAs continue to do. And what we have seen is that any interventions that address maternal and child mortality and family planning, fortunately, these still continue to be a priority. One other way how governments have been able to integrate this is by combining services during various visits. For example, during the postpartum visits, they have ensured that one of the key components that ASHAs try to address is around family planning. Similarly, they have introduced birth preparedness as a key component in ANC. So I think both ways, I think family planning is being addressed.
Well, thanks to you both. I think that there's a very interesting discussion, and yeah, I think it's certainly something, you know, as we are looking to ways to lower the burden a little bit of other cadres of health workers, that paying attention to not overburdening the community health workers as well, so that they're able to be effective, I think is definitely going to be an ongoing challenge. So thanks again for inviting me, Camille, and I'll turn it back over to you.
Thanks, Vince and Laura and Mahesh. So we're going to turn our attention to some of the questions coming in from our audience in the questions box. I'm going to start with, there are two questions about how CHWs can reach specifically adolescents and young unmarried people. So I know that we're seeing an increase in interest, an increase of attention to reaching young married adolescents and first-time parents. So I think these questions really are looking at unmarried. How do we reach unmarried adolescents? And I would just say briefly that I think one of the questions here is about where are good examples of projects that do this. I would mention Ethiopia's health extension workers, and they receive specific training on adolescent and youth sexual reproductive health, so they're encouraged to also provide information and methods to young people, including unmarried adolescents. And I'd like to turn this question to either of our presenters now about how ASHAs or how the community health workers in the programs you're familiar with, Laura, how they reach this specific population. So young people, and perhaps we could say something both about married adolescents, but also recognizing that unmarried adolescents are a population that's particularly hard to reach them with family planning services at community level, really at any level, but let's talk about how community health workers can contribute to reaching this particular population. So I'll start with Mahesh, if you want to say something about how this happens in your project, and then we'll ask Laura too.
Yeah, not specifically to this project, but I think in a few other projects, we've had experiences of ASHAs or the community health workers reaching adolescents. Firstly, since they are women, I think it's easier for ASHAs to reach out to female unmarried adolescents. And one of the programs that has facilitated this is the menstrual hygiene program. So increasingly, menstrual hygiene is being recognized as a key area of intervention. And ASHAs are also involved in social marketing of sanitary napkins in many areas. So I think this way, reaching adolescent unmarried girls is definitely feasible and is happening. Reaching unmarried adolescent boys is a different issue together, and so far I don't think ASHAs have been able to do that, and it's going to be really challenging reaching unmarried boys. So that's I think one of the examples I can give right away.
And I'd like to find out whether we still have Laura online. We may have lost her briefly. Laura, can you hear us?
Oh, yep, she's in Vincent's office.
Okay. Okay, so if Laura, if you can hear us, we'd like to hear what your experience has been with reaching specifically adolescents and unmarried youth.
Hello, can you hear me?
So we wanted to ask, I wanted to hear about how projects you are familiar with, how they reach specifically this population of adolescents and especially unmarried adolescents, how community health workers can contribute to reaching this population.
Okay. Yeah, I think there's been different strategies. That hasn't been our closest focus, but I think CHWs are, often there are peer educator groups that work with students in schools. So I think CHWs are really useful for reaching those out of school students or out of school youth. You know, there are a lot in Madagascar, and so that group is hard to reach with education and BCC strategies. So I think they've been useful for that.
Thanks. I think that in many projects that Pathfinder's been involved with, we've observed that just incorporating into CHW training attention to some of the social norm barriers that community health workers themselves may have regarding providing information and community-based distribution to unmarried or young people. So I think that's one of the main ways that we all try to address this in our work when we're able is to integrate it into trainings and refresher trainings and keep it on their radar. So now I'd like to move on to a couple questions we have about monitoring and about, where did that one go here, about referrals. So I'm going to put these two together. In my mind, anyway, they're related. One, Laura, seems clearly to be about something you mentioned, how communities can be involved in monitoring. And the other question, which you could also comment on, Laura, and I would like to ask Mahesh, is about referrals and counter referrals. What these look like in a rural community setting. And I know that's something that was difficult with the ASHAs because of the weak connection between community and facility. So if Mahesh, you could say something about how that referral and counter-referral works in your project, that would be very useful. Thanks. So let's start with Laura and what it means for communities to monitor community health workers.
Okay, so in our community engagement group, we worked, the community engagement group included the village, let's see, the head of the village, sorry, I'm sort of translating, Shifukutani, so the village chief, and the Kosan, who is sort of an elected person who was responsible for health and water and sanitation in their village. And so those two people were considered responsible for supporting the worker in their village. So they often filled the role of bridging between higher level officials like the mayor, who they have to report to make sure that the needs of the CHW are met, whether that's equipment or logistics, and making sure that they have a health hut. And so monitoring, so not technical monitoring necessarily, but very much sort of supporting and monitoring the work that they're doing and their availability to the community.
And I would just be curious also to know, what do you think this person, the chief that you mentioned, what is their, what keeps them motivated to support the community health worker? Are there other things in place that also increase that person's interest and attention to the community health work that's happening?
I mean, I think they consider themselves responsible for their community, for their village, and so they see this as a method of improving the health of their constituency, one could say. So the health of their community that they're responsible for. Maternal mortality, because of distances, maternal mortality is still very high in Madagascar, and so one of the key things is really helping that referral system and emergency evacuation system, and having CHWs there to help plan for those activities is useful, and sort of bringing the bridge and bringing key supplies both for child health and for family planning has been shown to be helpful. So the village chiefs are really supportive of that.
Thanks, Laura. So now, Mahesh, could you say a bit about this other question we have? This person would be interested to hear more about what the referrals and counter-referrals look like in rural community setting. Are they physical referrals on paper or given verbally? What do counter-referrals consist of? And I know that improving follow-up is something that MATRIKA project worked on, and you may want to say something about how mHealth may be used in the future in the project, for some of these. I'm not sure if it would be used to improve referral and counter-referral, but if you could say something about that, Mahesh, thanks.
Sure. So when we think of referral, the obvious thing that comes to mind is about referral slips. What we have seen time and again is referral slips do not necessarily benefit the client or the patient. They don't see an added value if they were to show the referral slip at the facility. But more importantly, they're so overwhelmed when they go to the facility that they most often do not show the referral slip at the facility. So what evolved over time is accompanied referral. So we had instances where ASHAs would invariably accompany the client. Example for, say, institutional delivery, or for, say, sterilization services. But this may not be possible every time. This increases the workload of the ASHAs and a lot of other issues. Coming to the project per se that we are implementing, we noticed that the key gap was the communication between the ASHA and the facility, the service providers at the facility. And hence, that was one of the motives to introduce the counselor. Now, since the time we have counselors, the ASHAs call up the counselor directly and inform of a client who she has referred. And when the client arrives at the facility, the counselor makes sure that the client, she receives the client and she acknowledges the fact that the client has been referred by the ASHA and connects up with the service provider. So the counselor is able to provide that critical link for inward referral. And I understand probably by counter referral you mean when the client goes back. So here again, this was not there previously because the service providers or nobody from the facility would definitely have the time or the inclination to call the ASHA and inform. So with the arrival of the counselor though, the counselor is able to inform the ASHA about any service received by the by the client on any family planning method, and thereby the counselor is able to follow up through the ASHA. So I think there has to be some link created at the facility if the referral has to work.
And also, I wonder if, sorry if I missed this, but would you like to say anything about how mHealth tools might contribute to both to referral systems, but also motivation and monitoring of the work in your project, Mahesh, in the future, or how you're thinking of using it?
Yes, so mHealth has the potential to automate many of the referral mechanisms. For example, by simple SMSs or by the use of an application, all referrals can automatically be received by somebody at the facility without the ASHA having to call and inform personally. Secondly, the reminders as well can go out directly to the ASHAs without somebody from the facility having to verbally call. More importantly, beyond the ASHAs, the mHealth will also be useful to directly connect with the client or the family planning adopter. So reminder messages, both in text or audio form, can obviously be automated, and I think it can help further strengthen the referral system, in my opinion.
Thank you. I'm going to read another, which is part comment and part question. We have an audience member who comments that the finding that you mentioned, Laura, on use of champion CHWs is one that World Vision has recognized and rolled out in many contexts, and currently researching in Cambodia and Guatemala, so we'll keep our eyes open for that research finding. She also comments that it's interesting to see, oh yeah, that's part of the same, interesting to see that here also. Then the question is the finding on injectables due to the higher competency levels of community health workers in Rwanda and Madagascar? This is from your presentation, Laura. And what literacy and training levels are the minimum standards for FP injectables? So I'll just say here that I think this varies by country. Obviously, each Ministry of Health is going to establish its own requirements for whether it's, first of all, whether it's allowed for injectables to be used at community level, and then what the requirements are for those who do it. we have also several other questions related to injectables, and I think we can say that there is, while Cyanopress is still being used, I believe, only in pilots. Some of those pilots are very large. A lot of it is focused on clinical use, but there are places where it is being piloted with CHWs. I think that there was also a question about whether CHWs might give women injectables for self-injection. As far as I know, but I welcome comments from if anybody knows differently. As far as I know, the use of sort of individual self-injection is only, I know it's recently been approved in Britain, but I'm not aware of that being tested yet in other places. So I'll have to look more into that. So let's go back to this question again. Laura, if you would like to say something more about competency levels of CHW and how that relates to use of injectables. And it sounded like this question is specifically about how injectables are used in Rwanda and Madagascar.
Okay, need to unmute, sorry. Like Camille said, I think this is more of a policy issue, and I was, Vince was talking some about policy, so I sort of tried to stay away from the policy issues to some extent. But as Camille stated, like this is really a Ministry of Health decision, But I think, so in all cases, in both Madagascar and Rwanda, there were pilots, and there are pilots in Mali right now to assure the safety and efficacy. But I don't think they're particular, in Mali, it's a higher educated cadre of matrons and aides-soignants. But the CHWs in Rwanda and Madagascar are not of that sort of educational background. So the requirement on paper in Madagascar is that they are literate and generally received 6 years of primary school education. But since they're chosen by the communities, they don't always have that criteria. And so that was sometimes a challenge just for use of job aids and such, but not necessarily for administering injectable contraceptives. So I wouldn't, it's a policy decision, and I wouldn't, I don't want to express any opinion that about a specific skill level specifically for, or a literacy level specifically for injectables.
Thanks. And so we also want to clarify, thanks for the suggestion, clarify that provision of injectables, community-based provision of injectables by community health workers is recognized, established as a best practice by World Health Organization, and we wanted to make that very clear. I think our discussion was about how Cyanopress fits into that and to what extent Cyanopress specifically is being used in different ways at community level. So we want to make very clear that use of injectables, provision of injectables by community health workers has been widely studied and is recognized internationally as a best practice. Okay,
yeah,
so
provision of implants is still, being piloted and being discussed, but provision of injectables is certainly a best practice internationally.
All right, we're nearly at time, so I recognize there are some questions we didn't get around to answering. If possible, we will try to reach out to you with additional information. We're really happy to have had all of you here listening and contributing your questions. Special thanks to Laura from IntraHealth and Vince from Frontline Health Workers Coalition, and sorry, the name of our week is Frontline Health Workers week. Is that the right name? And also special thanks to Mahesh for describing all of your work. And I think it's very valuable in these spaces and these webinars to be able to talk about what is what doesn't always go so easily, what doesn't always work so well, and how we're finding ways to adapt our best practices and our high impact practices to complicated and complex on the ground context. So I really enjoy hearing specific stories about how this works and different creative ways that people are addressing the challenges. Again, thanks very much for joining us. Please do take the time to chart your community health work experience if you are working on projects. If you're familiar with challenges that are being dealt with in your projects, you can fill out the form which is in the handouts box. I said chat box, but I was wrong before. It's the handout box, and you can also find the link to this high impact practice. Thanks very much for joining us today, and we hope to see you on future webinars.